My name is Dr. Kayita Godfrey. I'm a public health specialist, a medical doctor by training background. I have had a lot of work, and much of my work has actually been in management. Since I finished medical school for my first degree, I took up a job in an up-country district. That was in Masindi, and worked in a health center as in charge of the health sub-district, which I did for about 2 years. Out of the efforts and the activities that we had been engaged in trying to transform the activities at that health center level, I got promoted to become the medical superintendent of the district hospital in Masindi, which job I had for about a year and did a lot of work there. And I felt it was time for me to take on my master's course. So I took an MPH, which I had for about 2 years, and from there I came out and joined the ministry headquarters with heading the HIVCO program that had come in as a new project at that time. So I've enjoyed doing a lot of work, and much of my work has been in the managerial positions. But most of the managerial positions in the regional, in the district hospital or the facility hospital also carries a lot of clinical work. So I had an opportunity to do both clinical and management work until I finally settled within the Ministry of Health, where I do mainly management work. But again, when you do management work in HIV, sometimes if you go to the facility to do coaching and mentoring, it's not uncommon for you to be carried into clinical aspects, and you wind up in the clinic seeing clients as you help the facilities you've gone to clear the lines before you can get quality time to speak to them some of the issues that you could have come to do. Quality improvement in Uganda started way back as 1994. It came in to support the decentralized health system of the country at the time. The country was decentralizing, and we thought the districts that the powers were going to be devolved from the ministry had to work within a coordinated way and ensure that the quality of services is still okay. So these ideas of quality improvement came in, and they came in with the development of the quality assurance department at the ministry. It was put at such a high level that it would report to the Director General and the PS of the Ministry of Health, and then it would oversee services across the other departments of the ministry. Work then started. People were trained, and they came back in the country. They went overseas to train in quality improvement concepts and came back in the country and started implementing. Around 1998 to 2002, they implemented the Yellow Star program. That was a system of recognition and some award of the best performing facilities and individuals within healthcare. That work only ran between 1998 to 2002, not by design, but by the way it was funded. So when the funds dwindled, there was still some work happening in some few facilities that had taken, but facilities were at different levels of implementation. So in around 2005, through the HIV program, 2 projects came in. The Quality Assurance Project, which is now the Healthcare Improvement Project, and HIVQuad, for which I headed at the time, and helped to rebuild the quality improvement, especially in HIV. So worked on quality improvement in HIV for a time. We were able to transform HIVQuad from a project to a program within HIV, and later a unit of quality improvement within HIV, which still exists to date, with the funding that we got and the support we got from HIVQuad International at the time, which has now transformed into HealthQuad International with the coming of Bruce and his team. Bruce has been very instrumental. He came along. He came also with Margaret. Margaret became the country consultant, since Bruce had, I think, to oversee quite a number of many other countries. So Margaret has been very handy in supporting our program in country and seeing how it transforms into HealthQuad, and now we are trying to take it into a wider picture. HIVQuad, at the time that I headed, started with the 20 health facilities in 4 regions of the country. We had the central region, we had western, we had the eastern, and we didn't have northern at the time. So we divided them in a few regional referral hospitals in those areas of the West, Central and the East. We implemented those activities successfully for a year, and we thought it was time to expand these activities. Now the expansion was in two ways. The first part, we had implemented it within the adult HIV care clinic because those were the majority at the time in the country. After implementing it successfully and we were able to show that these innovations work and can yield to better results, we expanded to include the pediatric indicators. For that, we got some support from UNICEF, and we started in the northern part of the country. We got another 20 facilities in the north to implement the pediatric model of quality improvement. We continued with the other 20 for the adult, and we implemented it for around 6 months, the pediatric one together with the adult one. We saw that it was time to scale up to more facilities. We scaled up to 60 more facilities and took the number to about 120 facilities in the country that were implementing HIVCO. And we also did another thing. We now thought the pediatric model can also work, so we encouraged most of our facilities that had both the pediatric and the adult clinic to move in and implement both. So all the facilities implemented both the adult and the pediatric component of HIVCO. However, there were some facilities that never had a dedicated pediatric clinic. So those only kept moving forward with the adult part and looked at the adult indicators to see how they could implement these activities moving forward. We implemented that for about 3 years. And there was another global change. HIVCO was transforming into HealthQual, and in the country we maintained it as HIVCO. But also within the country, we felt that the partners for quality improvement needed to be better coordinated. There were a number of partners in the country. Almost each clinical or care and treatment partner in HIV came with their own model of quality improvement. So there was a diversity of models of quality improvement in the country, as many as the partners that existed, which led to confusion at the districts, confusion at the health facilities, and the confusion has started trickling up the Ministry of Health, with people scrambling for resources, people scrambling for space, people talking about facilities. So the HIV department thought about regionalization of partners. So we now asked partners to be in a particular region. And once we have a partner in a particular region, then we would ask the other partner to take on facilities within the other regions that existed in the country, since there was enough room in the country to serve and all the resources were required. That would help us to reduce duplication of efforts and also to help harmonize, because that reduced competition among the various partners that existed in this. This helped us a lot. So we are able to start on the coordination process of the partners and quality improvement in the country. We also moved ahead and harmonized indicators within the country for HIV. We brought all the partners together and they harmonized the training materials. We harmonized the indicators that we would use to monitor quality improvement in the country. So we now got a harmonized set of materials and a harmonized set for training. We divided the trainings into 3 parts. We had a part for introductory quality improvement that would take about 5 days. We had a component for continuing quality improvement that would be 3 days. We had a component for performance measurement that would be 3 days. So once somebody has had all those 3 trainings, we would assume this person is now complete in quality improvement. A few of those people would be selected to take on the TOT training. So they would become facilitators and support the regions and the partners in that regard. Uganda operates a decentralized health system. So in that way, every region has a number of districts where they can be able to support. So even the partners were regionalized, so they would support a region. And then they would ensure that these trainings happen and the facilities move ahead to implement. When we did that, we realized very fast that in the decentralized system of the country, you move from national level, which has the ministries, to the district level. The area of the region is not that recognized in that way. No clear administrative structure to support all the other facilities exists. So in that case, we chose to develop capacity at district level. We started to encourage districts to develop district quality improvement teams and start to support facilities within their district. But then they would receive technical support, and which could come in through mentoring and trainings from the national level and from the regional level through the regional referral hospitals and the partners that we have at that level. So we started implementing these activities. Very fast, the ministry realized that these efforts are only in HIV area. So there was need to take them across the HIV, across the health sector spectrum. We re-engaged the Quality Assurance Department at the Ministry of Health to see that we can take these efforts into that arena. On re-engaging the Quality Assurance Department, the first move the department thought about through the assistance of the Assistant Commissioner Quality Assurance, Dr. Sarah Byachika, was to have an evaluation of all the quality improvement efforts in the country, not only in HIV, but cross-cutting in the health sector. That moved ahead. It was supported by the previous evaluation that had happened. We had had 2 previous evaluations. We had had the countrywide evaluation of the HIFCO project, the HIFCO program. We had had an evaluation of quality of care activities within the HIV arena. So those 2 evaluations existed. So the Quality Assurance Department used those findings to carry out an evaluation of all the quality improvement activities in the country. That activity, I think, was supported by capacity projects worked very closely within the Quality Assurance Department. So an evaluation was done, and we looked at the various quality improvement initiatives that existed in the country. That led us into mechanisms of supporting these various efforts in the country and harmonizing them to reduce duplication and confusion at the districts and facilities. So that led to the development of the National Quality Improvement Framework, which framework was developed. The HIV unit had a lot to do with this particular activity that was happening, since a lot of experience had been gathered over years. We had about 6 years of working in the area of quality. So we are very key and instrumental in this development of the quality improvement framework. But before the quality improvement framework was developed, there was also change in administrative structures that we had overseeing quality at national level. The Quality Improvement Steering Committee was redesigned to become the Quality Improvement Coordination Committee, and the membership to it also changed to now include all the various heads of departments at the Ministry of Health to be represented. So it will become more representative and bigger. And it's chaired by the Director, Clinical Service, Director Planning, and the Secretariat is Quality Assurance Department, which will play a very big role in supporting the Secretariat part. After the evaluation, yes, we thought that we needed to be more inclusive. So we needed to bring all the other departments on board, apart from HIV, because there are positive results in the area of HIV. These efforts had played a very big part in the scale-up and expansion of HIV activities across the country, because they came in very handy at the time when we were expanding HIV services. At the time we had about almost like 200 facilities implementing ART, and by the time we were thinking about the big wider health sector spectrum, we almost had 500 health facilities implementing ART in the country. So it had helped in the scale up and in the maintenance of the quality of services across through mentoring and coaching and trainings that were happening at the time. So we used those observations and that experience to now try to engage all the other departments at the Ministry of Health to take part in these quality improvement activities and innovations. So now the committee has representation of all these people, with the chairperson as the Director Planning, under which the Quality Assurance Department falls, and the Secretariat as the Quality Assurance Department, for which we support.